I'm talking on a lens by care group, which is called Magnificent IOL, and this is beyond monofocal. So let's have a look at this particular the IOL, what it offers to us. We are always in search of the ideal IOL, and we know that though we need patients to see for far as well as near unaided most of the times, but the multifocals or trifocals may not be suitable for all patients, and there may be some limitations due to its design. But that's why we say that monofocal is suitable for all patients, and it's a no headache IOL. There is no need to neuroadapt with monofocal IOL, etc., etc. But is it really a no headache IOL? Are patients really happy with this monofocal IOL? So when we look at the refractive results after the monofocal IOLs, what we find is that though 80% of the patient lie within the plus minus 0.5 diopter refractive error post-operatively, still even using the best of the IOL calculation formulas, we have almost 20% eyes which have refractive error of more than 0.5 diopter. And does this error of say 0.75 diopter, does it really make a huge difference in the visual quality of the patient? So just have a look here. So this is the picture showing how a patient with 20 by 20 unaided vision will see the world. And you can see it is very crisp, clear. And if patient has residual, say myopic error of minus 0.75, this will be the simulated vision of the patient. It's good, but it's not as clear as someone who is absolutely metropic. So we have wow here when we have refractive error less than 0.5 diopter, but then it turns to okay vision when we have higher refractive error. So what my expectation was from the monofocal IOL was that it should at least give me unaided 20 by 20 distance visual acuity. And for that, we have to look beyond the standard monofocals. So this is the IOL which was launched by Care Group with the idea that it has a more depth of focus as compared to the monofocal IOL. So basically there is a central higher power which goes on reducing to the periphery. Thus the average power is same, but there is a central higher power which gives you a more depth of focus. At the same time, the modulation transfer function is quite similar to monofocal IOL within the range. So the patient is not going to lose any contrast, and from the refractive point of view, I think patient will have the same experience like a monofocal IOL. So this IOL was launched around 1.5 years back. So I had the opportunity to test these IOLs before its launch. And I studied this IOL versus the standard monofocal IOL of the Care Group. So the one arm included 80 eyes of the Magnificent IOL against 80 eyes of Acryol EC, which is their standard monofocal IOL. And these were the inclusion and exclusion criteria. Basically, I did the surgeries with patients who have potential vision of at least 20 by 20 without any ocular disease, and then followed this patient for 1 month, and then checked their distance, intermediate, and near visual acuity. And then I plotted depth of focus curve for each eye as per the after the correction. So what were the results? So I will just briefly tell you the results. Here, my main intention was to see whether this new monofocal IOL with slightly increased depth of focus, whether it improves the uncorrected visual acuity. So here, irrespective of the refractive error, what I found that in Magnificent IOL, 100% of these eyes had uncorrected visual acuity of more than 20 by 30, which was 80% with the standard Acryol EC monofocal IOL, which was a good improvement. Apart from that, as a bonus, we had these patients reading more or around 10 letters in almost all the eyes, which was equivalent to Snellen's near visual acuity of 20 by 60. So they had far better intermediate vision as compared to this was present only in 18% of the Acryol EC. And in near vision, it was 50% for the Magnificent and 9% of the Acryol EC. Just to give you a brief idea what this 20 by 60 Snellen near acuity means, that means patient can read easily the magazines or books with bigger fonts, but they cannot will not able to read the fine newspaper print always, but they can read the bigger prints. So that's one of the advantage of using this monofocal IOL with some depth of focus. Here I targeted only the emetropia in all the patients. So this was the depth of focus curve. You can see the blue line indicates the magnificent EDOF, and you can see the depth of focus is traced from 0 to around -1 diopter. Approximate 1 to 1.2 diopter was the depth of focus which I could get from this IOL. And as compared to that, the standard monofocal IOL had around 0.5 diopter of depth of focus. So there was improved intermediate vision because of this. So this is the application one. And then I further use this lens for another application. For example, here I wanted to improve the patient's intermediate vision as well. So I targeted always emetropia with their A constant of 119.3. But other way around, if I want, say, in a particular patient, I want the patient to see distance uncorrected vision as far as possible. I'm not worried about the intermediate vision. In such case, I targeted little bit of hyperopia, say around 0.3 to 0.35 diopters. And what it does is that it shifts the depth of focus around the 0. So there are higher chances that patient will land up with unaided 6/6 vision if we use this application with this IOL. So for a particular patient, you can choose what you want to target, considering there will be always some error in the formula. Now, the third application is use this along with monovision. So in a standard monovision treatment, we try to target the patient's dominant eye for the distance and the non-dominant eye to around, say, -1.5 to -2.5, depending on your choice. But most of the times what happens is that because there is no depth of focus in the monofocal IOL, patients tend to lose the stereopsis for the near vision. But if we use this as a blended monovision concept where the dominant eye is targeted for distance emetropia and non-dominant we target for around -1, still with the 1 to 1.25 diopter of extended depth, we'll achieve good near vision with the non-dominant eye. So these are the three different applications we can use with this IOL, and which I tried in my own patients. So it has a versatility. It is not just a monofocal IOL. With the depth of focus which it provides, we can decide whether we want to improve the patient's intermediate vision, or we want a better uncorrected distance vision, or improved and try blended monovision in that particular patient. So this is all from my side. I'm quite happy with this particular IOL technology because it offers a lot of different options as compared to a standard monofocal IOL.